So we'll move on then to our second speaker, Donald Combs from Eastern Virginia Medical School, talking about the Digital Patient Project. So now we're going to move from very large scale to individual modeling. And I'd like to, are you ready to take it away, please?
I am. I want to make sure I can share the screen. Do you see my slides? Okay. Well, thank you very much for the invitation to speak. And it's absolutely appropriate to follow Deborah Peters' presentation in the sense that her emphasis on how you organize a project. I'm sorry?
Before that, you're not in presentation mode. If you want to be.
No, I wanted that way it can track on the left where I am.
Okay, that's fine. Sorry, I just wanted to make sure you, I apologize. Please start.
It was actually intentional.
Okay,
Not everything I do on the computer is. At any rate, I think her emphasis on the importance of organization is really important because this is not so much a brand new project or a startup, but a reinvigoration of an existing project. And I want to spend a little bit of time trying to do some definitions. But the image that I want to start with, and I think almost everybody will be familiar with it, is Charles Dickens' Christmas Story, where the character Scrooge is visited by three ghosts, the ghost of Christmas past, present, and future. And you can see in letting the story unfold the factors that led to him being the way that he is, and if he doesn't change, the differential outcomes in the future. And I think that's what we hope for ultimately with the digital patient, is to be able to understand the factors that lead to a current status of health and understand the implications of different approaches thereafter. So let me get going here. So I think it's important to start with the big goal, and the big goal I think is pretty well captured in the by the Institute of Medicine when they talk about what do we want from healthcare. Well, we want it to be safe, we want it to be effective, we want it to be relevant to me, we want it to be timely, we want it to be efficient, we want it to be equitable. And all of those variables as a measure of the quality of healthcare are important, and this is where the digital patient, once realized in some number of decades, could help address these issues, I think, very carefully. This focus on the digital patient is part of a regional effort in Eastern Virginia that involves developing a platform and applications, as I'm going to talk about with the digital patient, but also assembling a huge amount of data from healthcare systems, from the Census Bureau, from the cities, from individual practitioners, from patient histories, into what these days used to be called a data warehouse, but now I guess it's a data lake. And so we're in the process of creating such a thing regionally with huge amounts of different sorts of data. And the purpose is then, can we take an application, which the digital patient is, and draw on all those sorts of data to build something that is useful. So the effort that I'm going to describe, or the thinking coming forward, is built on the efforts of lots and lots of people. I edited a book on this about 6 years ago, trying to pull together the work literally of hundreds of individual scientists around the world. And then there's kind of been a pause because it's such a big project. So it's important, and if we can build it, it will really, really, really make a difference in improving healthcare. So what is a digital patient? It's the latest in a long line of development. Back in the 1990s, the International Union of Physiologists started, well, actually before that, even the United States started. Remember the male and female that were sliced and diced anatomically, called the visible human? That was an effort to begin to build a model of the structure that was far more sophisticated than we'd ever had. That was a late 80s project. In the early 90s, the Physiome Project, Peter Hunter down in Auckland, among others, headed that up to build a physiological model of the human body, all of the processes. So if the anatomy gives us the structure, the physiome gives us the processes. In the early 2000s, the European Union funded a project called the Discipulus, the virtual human physiome, trying to go beyond the modeling that was traditionally done and is still done in physiology. And they've spent about 5 years, stopped around 2015. The funding stopped, and it morphed for a little while into something called Avicenna, but it's been pretty much stillborn. And so what we're talking about is an effort to reinvigorate the notion of what we're now calling the digital patient. So what is a digital patient? And this becomes really important. Taking one of the European Union workers on the Virtual Human Project, Vanessa Diaz-Sucarini, defines it as a technical framework that once fully developed will make it possible to create a computer representation of the health status of each citizen that is descriptive, interpretive, integrative, and predictive. That's a really good definition if you draw a circle around the world framework. That's what we're focusing on. There are lots of people working on different models in silico, viral models. Dr. Glaser wrote an article with some colleagues not long ago about the notion of digital twins. There's a lot of discussion about models. In fact, this group is a part of an interagency modeling group at a federal level. There are lots of related concepts to this framework. Artificial intelligence, I already talked about data lakes. You can pick up journals every day and read about things like organs on chips and artificial organs and in silico R&D, different taxonomies for what the pieces are, how they fit together in ontologies. The point being that there is an interest in the big picture, which is what I'm interested in, the digital patient. There's been a lot more interest in people building specific, generally physiological models of heart-lung interaction, of kidney interaction, of the process by groups like the HumMod group at Mississippi or the BioGears group that are trying to build, and all kinds of in silico models in pharma that are trying to build pieces. And so, for example, the digital twin to me is a subset of a digital patient because it's more narrowly focused. The notion of a twin is it's a twin to something that exists. It's only virtual rather than the real thing. The digital patient I'm envisioning really as a platform where lots of things can go together. And so I think this slide kind of captures it of the digital patient's right in the middle, but it's built, it is not built today, and it's going to be quite a while before it is, will be built on data sources ranging from the molecular to the neighborhood. And that's a major multi-level modeling challenge because not only is it multi-scale from the molecular to the social, because we know, for example, obesity is related to family and friends and neighborhood customs and culture and behaviors. And we've got to get that sort of data. We can't just stay inside the human body, but even if we stay in the human body, the scale of time varies greatly from what's going on at a molecular level to a tissue level. We have to make all of that somehow fit together. So what we are planning to focus on here is not doing so much of the individual work, although we want to test it, is we want to try to build an open source platform that people can plug in all sorts of data that over decades will grow into the capacity to do a digital patient, where they might, for example, take my actual data on, they might do a variety of lab studies and X-ray type studies of my cardiovascular system, but then they might not have as good data on, say, kidney function. And the idea would be you could take some of my personal data and take normative data from a normal kidney and plug it in and at least run that model going forward so that you have some actual data and some normative data. But in order to do that, you have to build an open source platform where people can drop in different pieces of the data and run analyses. And that's what we're talking about here. just not to spend any time, but this is the range of issues that we have to deal with, everything from structured data to semi-structured data to somebody's verbal recollections, and how do you pull all that together to get the information that you need. These are issues that we're going to have to address. So I hope in a very quick period of time, without the sort of specificity you would give in an article, I've outlined the big picture of what it is we hope to do with our digital patient project, and that is to build a platform that people can take existing models and existing data developed for different purposes, some of it real time, some of it historic, so that we can move toward this notion of getting a model that really allows us to understand history, understand more fully what's going on today, and project alternative futures based on interventions. I've chosen to highlight just a few challenges. There are undoubtedly hundreds of them, but one of them is making a user interface that makes it relatively easy for people to import data and run analyses. And in that platform, it has the capacity to pull together data on different organ systems and plug in the missing pieces to calibrate between different space and time scales. That's a huge challenge, obviously. Another challenge is, and it's interesting that the EU effort wasn't funded on the healthcare side of their funding, it was funded on the ICT side, because they understood the biggest barrier is getting a platform where people can, I know it's not a great analogy, but like build a Lego castle. You can put pieces together in different ways to come up with a different result that is coherent. Providing, we would think that in 2021, there is a common definition of a knee and what connects to the knee. But in fact, there are subtle variations. Some models include almost everything. Other models include less. And one of the keys to this effort is to work with those agencies that have been working on these issues for a long time, but to get an adoption of a commonly understood taxonomy and ontology among all of these types of data that have to come together to build a digital patient. When you start talking about massive data and repositories and who's going to own it and who's going to own access, it raises a whole bunch of issues. And we have to begin to at least, again, set a framework of how we're going to talk about that. In today's paper was a lengthy story about the new regulations on the use of artificial intelligence issued by the EU Commission just yesterday. So there's a lot of attention, and it's understandable if we get this kind of data about individuals that we've never had before, the possible abuses are enormous. And so we've really got to pay attention to that in design. Another challenge is, this is kind of the framework, the challenge is that we need to build a group of people that are interested in focusing on the digital patient platform. It's the kind of commons problem that was written about many decades ago. In order to really advance in silico medicine, in order to look at quick, rapid vaccine development, for example, in the COVID-19 pandemic, there's a lot of interest in being able to do things in silico very quickly. But that will involve collaboration across research programs, and it will involve people not only paying attention to the particular issue that they're investigating, but to the broader environment and how that piece may fit into that broader environment. So my point being is this is not going to be done in Hampton Roads, Virginia. It's not going to be done in Virginia or in the United States. We've got to figure out a way to get points of view from all around the world. I don't mean every country has to have a representative, but we need enough diversity of points of view, thinking about how do we build the commons, what are the constraints, what are the capabilities, And I'm hoping that we'll spend the next year convening people to address that issue. As Deborah Peters showed in her slide, it really helps to have a conceptual model, an end goal of what it is you're trying to address. And this is such a big issue that we need to spend some time trying to get the definition of what it will do and won't do. That's really a slide that just says, in order to realize a digital patient, we're going to have to be open to new knowledge. I think all of us that have lived through this COVID-19 pandemic have perhaps been struck by the importance of the word novel. I know I didn't appreciate the full dimensionality of what a novel virus really means. It means we don't know that much about it. And so all of a sudden we're getting what, 1/3 of the cases that are spread by asymptomatic people. And we're getting some people that are indicating respiratory distress, but we have other people that have orange toes. And both of those are indicators of COVID. And the fact that it's novel, what I'm talking about in a digital patient platform is going to be new. And we're going to have to pay a lot of attention to how we build in flexibility so that it evolves over time. We're in the startup process. And so in my thinking about this, and I think Deborah did a really good job of, you need to bring people from different points of view together, and you need to spend some time getting the current lay of the land. There have been people working on who continue to work on building physiological models. There are other people that are looking at doing digital twins for very small slices, either a virus or an individual. We need to bring people together to say, the only way we're going to get to where we want to get. So for example, testing a new vaccine against a virus, you can do that at a molecular level, really small, seeing does it target that, but it doesn't then take into account all the stuff that we were just talking about, when you get to the level of the full human or of the neighborhood, and behaviors in the neighborhood as well as individual behaviors affect the course of what's going on at a molecular level. And we need to be able to have a group that can help us think through how you build a model that is robust, that is practical, that's adaptable, isn't so complicated that we can't do it, but at the same time is more complicated than all of the models that are out there now. Dr. Glazier, I think I'll stop there. I was right at the end of my time, I think, anyway. And we can proceed how you want.
Lovely, thank you. So we actually, despite the breadth of both talks, they were delivered with breathtaking speed. So we have time for some general questions before we go into our open forum. As usual, the request for the questions during the formal meeting time is that we try to hear from people who maybe don't speak up so much, and the questions should be kept relatively non-technical. And all gloves are off in the second session. So any questions for either of our speakers now?
I'd be happy to ask one to Deborah Peters. I don't think this is a gloves off type of question. So, so great talk. I think the question is for the vector-borne disease and the modeling, how you would imagine expanding your approach to vector-borne human diseases like Zika, where you've got mosquitoes that you're concerned about. And maybe the further extension is if it's not necessarily vector-borne and you think about COVID. So the extensions, challenges and opportunities there.
Yeah, so we have a paper we just submitted on a West Nile human disease spread. So we've gone that direction. And And then, you know, Triple E, I think the issue is whether you have enough response data to actually work with. So Triple E, we think we have, we tried to do blue tongue, but we couldn't get enough data. So I think it's sort of, there's lots of environmental data, right? So when I think of the driver data, there's a lot of that. It's the response data that typically limits what we can do. So I think otherwise, you know, we're open to certainly collaborating. Now we have the expertise in VSV, and we can sort of go to West Nile and Tripoli, but I think we would need collaborators, right? Really want to get with people who understand the system. And my group recognizes, you know, my team here in Las Cruces recognizes, you know, we don't know anything about these diseases. And so we need to have the experts. We listen really well, you know, and so then we can put it together, but we need the experts in the room. And I think we took 6 or 8 months just peppering the VSV team with lots and lots of questions, just over and over again. You know, we just asked them lots of questions about what are the vectors, where do they live, where do you see them? Is it different in New Mexico and Colorado or Montana? I mean, we have all these questions that before we actually, you know, went after the data. And I think people jumped to the data a little too quickly, but we wanted to understand as much as we could before you know, it still costs me money to have my people get those data, right? So I wanted to be sure that I was going after the right data before we did. So then the second half of your question has to do with like COVID. So I think as long as there's a environmental aspect to it, right? I think we can expand this approach because I think it's sufficiently general, and that's sort of where our comfort zone is. So I think otherwise, if we wanted to go to other diseases that don't have any environmental, I'm not sure how I could help. I'm not sure I could be the best person to help, but I'd be willing to try. So that I'll leave. You're ready to ask another one.
Couldn't one argue that all these emergent, zoonotic spillovers are environmental, or are you, the disruption of ecosystems? And I wonder, so it seems like you would be best positioned to be able to address these kinds of, predict potential for that.
Yeah, I mean, I need people to work with because I'm not going to have that expertise, but absolutely, yeah.
Great, thank you.
We have time for 1 or 2 more general questions.
I have a question, perhaps for Deborah Peters, and it's probably relevant also to Don Combs, which is the challenges of an interdisciplinary team. So maybe you could say something about how you went about putting the team together, recruiting, training, and communication, some advice, lessons learned, anything like that?
Yeah, so we had never worked together. So it wasn't like we had a history. Luis knew the people who were doing the right work, right? Like the insect people in Kansas that he knew about, but we had never worked together. So it was sort of starting from scratch. And I think identifying team players is really important. There are always going to be options on who to sort of bring into the team, but I think we were very careful to bring in people who wanted to collaborate, who were interested in listening to everybody's perspective and everybody's view. We don't have anybody sort of running over anybody else. I think also the team, everybody has sort of their own role. So that also helps, right? Because we acknowledge there are certain experts in things and they're the experts, right? So we go to them. I think we also have regular meetings. We actually meet twice a year. We have monthly phone calls, and then we were meeting in person. And we went around, we just kept moving. And we started in Fort Collins, and we came to Las Cruces, and then we went to Plum Island, and then to Manhattan, Kansas, and then we started around again, right? So we just had our 10th meeting. Now this one and the last one, of course, were virtual. But we actually went to each location, and that really helped a lot because each person could host it, had their own people. And I think the last thing I would say is that we've expanded. So we started with 5 or 6, and we're at 15, I think now. And so as we sort of, we're also, we start with one very general pattern, and now we're sort of looking, okay, how do the insects get across the border from Mexico? That's a separate question, right? So I think we're also expanding, our breadth of what our interests are. And so we need more people, and recognizing that when you need more people and bringing those people into the team.
Okay, there was a question for Donald in the chat. Could you imagine a version of the digital patient that was decentralized to avoid privacy worries about doing artificial intelligence on data being gathered and concentrated in a small number of places?
Yes, and thanks for bringing up one point as I was trying to cover a lot of ground that I think I only mentioned. Most of the physiological modeling that's been done so far is traditional. It's top down. It's based on the investigators' hypotheses and model and constructing it together. And that's a part of my looking for people to collaborate is I want to think about this in 2021, not in 1980, 97, 2005, where not only do we have top-down modeling, we have bottom-up modeling. And the point that you raise is an excellent one that is worthy of discussion and exploration. Can you park data in lots of different places and in real time quickly aggregate it to solve a particular problem? And that's kind of my notion, which I hope I covered in, is I think the digital patient is ultimately a confederation, not only of types of data, but of different models. And what we want to do is not be perfect, but be good enough. And that notion about decentralizing is a good observation. I want to just follow up to Deborah's comment on the team. I've got a fair amount of experience in modeling and simulation, know people pretty well internationally as well. But this is, as I said, not a new effort, but a reinvigorated effort. And so we are going to start, in addition to myself and my co-principal investigator, with a staff of 4. One person who's totally dedicated to reading the literature and telling us what's going on, looking at the web. And that's the first person I've hired. And she's busily at work, going to educate us about what it means to be in 2021, because I don't know. We're going to recruit somebody who's a specialist in medical modeling and simulation, somebody who's a computational biologist, and somebody whose competence is in bioinformatics. And we think that team will give us the oomph to take these general concepts to the next level. We're recruiting now, and by the way, if it's okay, if it doesn't break a protocol, I would love to send an email to everybody who's on the list of this group, say if you know anybody who may be interested. I had originally thought about hiring PhD faculty types, but I've subsequently said I'm really interested maybe in postdocs or even really smart masters who may be more up to date than the other, but it also may be an opportunity for them to get involved. And so is that okay, Dr. Glazier, to send that?
That would be. I'm sure that everyone on the call and the working group who has graduate students and postdocs who are looking for positions would be delighted to know about the opportunity.
All right.
So we'd be happy to distribute them.
All right. We'll get it out tomorrow. Thank you.
Okay. Before we just come back to our usual slide to close the formal part of the meeting before we have our open discussion, which is that we always I would like your comments and feedback about how we can do better. We have some subgroup meetings scheduled, as you heard. We have some reports from subgroups. It's great. Let us know what you'd like to present. Any way we could publicize these Thursday meetings to reach a broader audience. As you see, our topics are diverse, and so we want to make sure that your communities are served by these meetings. Please let us know. Anybody who wants to have ideas for the steering group is most welcome to suggest them. And I think, especially in context of the 2 talks we've heard, we've been thinking a lot in the steering committee and elsewhere about the ultimate aims of this working group. And I think in many ways, the Digital Patient Project that we just heard about is very parallel to some of the things we've been thinking about. Anyway, we can translate the excitement of this group into actionable results is wonderful, and we'd like to hear your ideas. And so we'd appreciate anything that you want to talk to us about. Reinhard, do you have any subsequent things you want to talk about before we move to the open discussion?
Nothing further.
James,
John, please.
John Rice. Yeah. Can I grab about 2 or 3 minutes here to introduce the idea that's been offered to us from IMAG?
Please, go ahead.
Okay. Bruce, if you throw that slide up. Basically, we got communication in the dissemination outreach group from Grace Pang that since their March meeting had been canceled, the organizers preferred to wait till next year when they can do theirs live, that we've been offered the opportunity to create and host what would be the IMAG Multiscale Modeling Consortium annual meeting. And so having talked with my subgroup and talked with the steering group here, have had support for taking that on. And what I just want to quickly share is the kind of construct of it that because it's going to be virtual, in spite of the limitations, like we would really rather see skin and eyeballs together, there's a lot of other things that we could do this time that would really help from the outreach perspective. So in working through some of these ideas, the conference, the way it's envisioned, and we have not, by the way, accepted the job yet. This is with you guys, because if you're not interested, we're not going to be able to do it. But I've envisioned it as having 3 primary parts. One is the typical programmatic IMAG, MSMC, their working groups, time for their working groups to report out, break out into breakout rooms for their working groups to have an hour meeting. For those of you who have been in Bethesda, you understand that part. The other part that's significant is the normal scientific meeting that the MSMC community has, which is the presentation of models and things and papers. But this, we have a lot more opportunity to reach out because it's virtual to people who normally don't get to attend the meetings in Bethesda. And so in this context, my kind of offer or request to you all is I would like to set this up where the scientific part of this meeting is actually organized and hosted by the virus pandemic new working group, and taking advantage of all the topics that we have and the subgroups, you know, that subgroup chairs would be willing to become the track chairs for a track of 2, 3, 4 sessions related to what your subgroup is trying to do, so that your own people can exchange information, but you can also do a call for papers for virus-focused papers in your subgroup topic areas to construct your own tracks. And then the other part would be a thematic one, and just, you know, right now it's just to take advantage of the outreach things to bring in people from other areas and other disciplines to do some sessions, some panels, interoperability panels on FDA and what FDA is expecting, panels from industry to hear from industry what they would like to be able to hire coming out of your university training programs, that type of thing. So with that much time available, I would ask if Jim, you could still assign me a breakout room that will not be open for at least 15 minutes. I would hang around and wait for people to finish up talking to speakers. And if you want to ask questions, otherwise we'll be following up with an email very soon asking you specifically if you want to talk about track sharing. Thank you.
Thank you, John. Okay, with that, our regular meeting is closed and we now have our discussion. We have two people with enormous expertise here. I hope that it will be a lively discussion.